You have to look at those meds and see what you're taking and why you're taking it. Mood disorders. I cannot tell you how many times your population does not get treated for depression. This is not a generation of people that said, oh, gee, I'm feeling sad, I'll go see the psychiatrist and get some medication, right? Didn't happen. Depression has a social stigma, has a value judgment to it that if you're depressed, you should be able to pull yourself up by your bootstraps and move on, right? You can get over this. Clinical depression is chemical. It is about neurotransmitters. It's about dopamine. It's about serotonin. It's about norepinephrine. If you went to the GP and he said your hemoglobin A1C was 8, you have diabetes, you're not making insulin anymore, you wouldn't say, oh no, I'm going to pull myself up on my bootstraps and I'm going to get myself some more insulin, right? But you're clinically depressed. You don't want to get out of bed. You're hopeless. You feel like you don't enjoy anything you used to enjoy before. Getting through life is like trudging through mud. You don't have enough serotonin. You don't have enough norepinephrine. You don't have enough dopamine. And yet, for some reason, we don't want to take those medications. But treating depression can significantly benefit your cognitive abilities. Extremely important. And then the periodic evaluations detect subtle changes. So why do I go back to the neurologist every 6 months? Well, you go back because clinical eyes on you is different than what you're seeing every day. And hopefully that provider is going to help you when they see those changes for you and help direct you in the right way. And then an interdisciplinary collaboration, right? So you need the neurologist, you need the neuropsychologist. You should be having that neuropsych testing done every 1 to 2 years after you have it done. So you can see where the progression is, so you can see where the deficits are that you need assistance with. And then psychiatric professionals to really be able to treat the anxiety and the depression that comes along with this disease. All right, so we talked a little bit about this. I try not to get a little bit mixed up sometimes in my talks and talk ahead of things, so I'll re-go over a couple of these things. But cognitive decline impairs our ability to manage daily tasks and routines, right? I mean, that's kind of a given, right? But I'm going to, one of the ones I wanted to talk about this, and the reason why this was really important to me was difficulty in medication management. This is the 3rd leading cause of death in the elderly, is medication errors. 1.5 million people annually will be affected and will be hospitalized for taking the wrong medications. For not taking them the way they're supposed to, or abruptly stopping them. So if you are struggling with your activities of daily living, if you're struggling with your executive function, you being the person who fill up your pillbox can actually be deadly to you. So again, it's one of those times when you really have to look at the seriousness of this and ask for help. You think you can do it, but if you've got a cardiologist and you're on multiple different cardiac meds, you have to be very careful about how you're using this. Social and safety concerns. So again, this affects that social interaction, which we talked about, right? Not recognizing that when the phone rings and it's the FDIC, that it's not really the FDIC, right? Reduced awareness can compromise personal safety, right? In your home and out in public. If you're not really aware of the situation or how to process that information, you're at risk, especially, here in Florida when life moves really fast. I talk about this a lot in terms of people with driving. It's not you that isn't a safe driver. It's the person behind you who's practically going to run you off the road because you're actually doing the speed limit, or because you slow down to, take that turn and they're right up on the back of you. So again, it's a lot of times when I have to talk to people about getting up their driver's license, which is extremely difficult and is a huge impact on your independence, you have to realize it's your reaction time, it's your ability to manage being on the roads down here is oftentimes more of an impact in your ability to drive. And then we get to caregiver burden, which, again, nobody wants to be a burden. and nobody wants to have to rely on other people. But progression of cognitive symptoms increases that caregiver stress because that person has to look out for you all the time. They have to look out for everything that you're doing, and they need to support you in all of those things. And so this is another impact on our activities of daily living and aspects of our life. So, management. The first thing we can do is we want to optimize the dopaminergic therapy to address cognitive symptoms. So making sure that you are seeing your neurologist, that you are taking your Cinemat, that you're taking your Rytari, whichever agent that you're on in order to manage your dopamine symptoms. It's very important for your cognition that we try to maximize those dopaminergic meds. Rivastigmine is the only acetylcholine inhibitor that's actually approved for FDA approved for Parkinson's disease, but it's very important to consider the cholinesterase inhibitors for dementia and Parkinson's disease. You know, and a lot of times people are like, well, it didn't do anything. I didn't get any better. You're not going to get better. Our goal is to try to keep you steady. When people go on these medications and their thought is they're going to get better, they're setting themselves up for failure. We can't make the cognition get better. The best we can do is hold it steady at where you are when you find diagnosed and on these therapies. Lifestyle modifications. You know, we talk about this all the time, promoting healthy sleep routines. If you have REM sleep disorder, one of the best ways to treat REM sleep disorder is with good sleep hygiene. And sleep hygiene isn't just I go to bed at the same time every night. It's getting outside and getting sunlight during the day. It's making sure your vitamin D and your B12 is good. It's maintaining a routine for your sleep. You know, when you do go to bed at night, and medications that you take at night before you go to sleep, and making sure if you have sleep apnea that your sleep apnea is treated. And these are all things that are going to promote better sleep. And when we sleep better, we feel better. And when we sleep better, our mood is better. And when we sleep better, we have more energy. Non-pharmacological interventions. So this is where we talk about cognitive rehabilitation programs. And this is a lot of what we do at Town Square as well. All of our activities at Town Square are based on cognitive rehabilitation. It's not just coloring. It's not just music or art therapy. We actually have evidence-based programming that we do that shows increase in stimulating your brain and keeping your brain active and functioning. And it's important. When people say, oh, I play games. I play games on the computer. It's not the same as cognitive rehabilitation. And then again, the multidisciplinary approach. Don't forget those other folks that are out there. And especially for me, it's my specialty, the psychiatric side. Because nobody really wants to talk about that side. Nobody wants to talk about the anxiety and depression. But it impacts it in a huge way. So again, research has been amazing. We've learned a tremendous amount in the 35 years that I've been practicing compared to when we started. But again, sometimes the therapies kind of get ahead of, and the research gets ahead of what we're able to do in clinical practice. And everybody, you know, wants to be able to benefit from all of these things. One of the big ones right now is the new medications that are out for slowing down the Alzheimer's disease, the lecanemab and the donanemab. So these are all, you know, therapies that have risks, they have benefits, but, you know, again, we're pacing it. We're trying to keep up with what we're learning with what we're also able to put out into clinical practice. The biomarkers have been amazing. We definitely, our early detection and monitoring of cognitive changes has definitely been changed by the biomarkers. And this is really important in, again, getting us to be able to diagnose this disease earlier. The one thing about both of these diseases, both Parkinson's disease and Parkinson's dementia, is they are diagnosed way too late. Way too late. And so this is an area that we've really been working towards in making positive inroads to be able to diagnose this much earlier so that we can make impact earlier in people's lives. And then, you know, it's really important for us to be able to tailor that treatment. So we're also looking at genetic and clinical profiles that are sort of under investigation and trials that would evaluate targeting therapies so that we can really focus on the cognitive issues as well. So, takeaways. Cognitive changes in dementia. Cognitive decline often emerges as the disease progresses, including memory, attention, and executive function. Importance of early detection, so timely assessment, enables tailored intervention so we can help support you the best we can, improve your quality of life. A multidisciplinary management approach, so making sure we're doing cognitive rehabilitation, making sure your mood and your behavior and your neurologists are all working together to come up with that comprehensive care plan for you. And then obviously the ongoing research that we're doing in order to try to get to a better place in diagnosing these diseases earlier. Questions?
Should all Parkinson patients, would you recommend all Parkinson patients have as part of their care team someone with your background, clinical, is it clinical psychology?
I'm a psychiatric mental health nurse practitioner.
Okay.
So the question is, should everybody who has Parkinson's disease have somebody like myself in their care team? The answer to that question is yes. And again, psychiatry is, there are multiple different types of providers in psychiatry. There's licensed clinical social workers, there's clinical psychologists, there's psychiatrists, there's psychiatric nurse practitioners. It's a combination of things in psychiatry. You know, we live in a world where people want a pill to fix everything. In the world of psychiatry, you really need that psychological support. Oftentimes therapy, oftentimes talk therapy, cognitive behavioral therapy really helps people deal with the emotional impact of being diagnosed with a disease like Parkinson's disease. I don't think any of you can say who have been diagnosed with Parkinson's disease that it didn't impact your mental health in one way or another. And nobody's happy to get that diagnosis. And how you deal with the grief, the loss, the ability to come to a level of acceptance for what you have, that's a psychiatric issue. And to do it alone, you know, is, you know, we can all do our taxes ourselves, right? But is really the best way to do it, right? So reaching out for that professional help. So yes, my professional bias is that you should have a psychiatric provider. And you can start with a clinical psychologist and say, I just want to talk through this. And then they may say to you at some point, you know what, you really would benefit from talking to a professional who can consider medication for you.
Do you accept insurance, and can you do the cognitive assessments?
So here's a plug for myself there, Skylar, thank you. So I do have a practice, a psychiatric practice. I see patients at Town Square, University Park. I also have an office on State Road 64 in Bradenton. So, and I do the cognitive assessment in terms of the psychiatric needs. I am a Medicare provider, so I accept Medicare, Medicare Advantage, and pretty much all Medicare PPOs, not the HMOs, unfortunately, but the PPOs. And so oftentimes people will come to me and say, I am struggling with this, and this is something I would like to have more information about and get treated for me so that I can, you know, feel better about the situation. Yes, ma'am.
I think that probably everybody has experienced this, but it's extremely difficult to actually get in to see the necessary one.
Yeah, I understand what you're
We've
saying.
been waiting for cognitive testing for months, and then just yesterday they called and canceled the appointment and rescheduled it for 2 more months.
I do apologize for our whole profession.
There just aren't that many
Right.
having that specialty.
It's very true. And that was very surprising to me when I moved down here. I'm from Connecticut. And when I moved down here to Florida, the point is that it's very difficult to find providers that do this and to get in with providers that do this. There's sort of this wave now moving towards concierge providers, which is private pay because of the insurance issues. And so there are physicians or neurocognitive providers that will do neurocognitive testing for an out-of-pocket fee, and you can typically get in with them faster. But if you are relying on insurance, unfortunately, yeah, it does take some time. Which brings me back to that idea of you need to get better at diagnosing this sooner so that you have the ability to get in, you know, within a reasonable amount of time. So, and again, this is part of what we do at Town Square as well, because we really try to be that resource person for you. We have over, what was the last count? Over 4,000 resource partners.
Oh, yeah.
That we have for people, things that they didn't even think about or they didn't even understand could potentially help them. Because there isn't you talk about dementia as a medical issue and cognitive impairment, and the reality of it is that there's no respect in our medical community and society for dementia. If you got diagnosed with cancer, you leave the cancer center with a whole team of people helping you. Whereas when you get diagnosed with Parkinson's, dementia, or dementia of any type, kind of get a, here's some meds, see you in 6 months, and there's no resources for you. But it's a disease that requires inordinate amount of resources in order to be able to treat and to live with every day. You recognize that? Yes, sir.
All of us in this room know the value of exercise.
Correct.
What is the impact of exercise?
So,
Dementia?
right. So the question is exercise, and what's the value of exercise in terms of Parkinson's and dementia as well. So a couple of, it's a multi-factor kind of an answer. So when we exercise, we do increase our own natural endorphins, and one of those is dopamine. So obviously, our endogenous, which is the dopamine that we create from inside of our body, the more we can create that, the better off we are. So that's why exercise is very important. In terms of cognitive impairment, blood flow to the brain is very important. And so when we exercise, we also increase the blood supply and blood flow to it. So on a regular basis, when we are exercising, we're keeping our brain healthier, just like we're keeping our heart healthier, and we're keeping our muscles and limbs healthier. So exercise really is incredibly important. Our generations ago, they didn't exercise. They didn't have LA Fitnesses, right? Because they were out working the farms, and they were walking places, and they were, my husband and I just got back from Barcelona, and we walked like you would not believe. Like I didn't think I could walk that many miles in a day, right? But that exercise, they don't have to go to the gym and speed, because that's what they do. They walk, right? And they live in apartments where they carry their groceries up and down the stairs, right? So they do weight-bearing exercise without having to grab weights like this, just from their lifestyle. So sometimes it's lifestyle, and sometimes it is if you do have that sedentary lifestyle, finding a way to integrate that exercise. But, again, it's one of the keys, but most of us don't want to exercise. Anything else?
A lot of times we hear they can't get in with different specialists for months on end. On average, how long does it take to get seen at Town Square and or with your practice?
So on average, we get people in within usually 4 to 6 weeks at the latest. And then again, once you're hooked in with a provider, oftentimes it's a little easier sometimes to get that referral to another provider and to get in with other providers. So sometimes we can move you to the head of one.
Is it free to get assessed at Town Square?
Yeah, so we do, at Town Square, we also do what we call an educational assessment. There's a lot of times that family members will say to us, like, I'm not really sure if mom's cognitively impaired. I don't even know where to start. And so oftentimes they'll come in and we'll do an educational assessment where we'll go through some basic medical history, we'll do a mental status exam, and then we can kind of talk with you about what we see and what are the next best steps for you as you move forward. So, really our goal at Town Square is to become that resource center, that center for dementia excellence, that people can come in, whether they utilize our resources or not, whether or not they come to our Parkinson's support group, our grief and loss support group, our early onset support group. We've got more support groups. I can't even keep track of them anymore. And I hear daily from people how helpful they are as people learn more and find the resources that they can get. So that's one of the things that we do at Town Square, which I oftentimes feel is very similar to what happens for you folks here at Parkinson's Place, is that you're able to find those resources that you need for the things that are coming up. All right. Thank you.